SCAAR is abbreviation for Swedish Coronary Angioplasty and Angiography Registry. It's our national registry that has practically 100% coverage of all angiography and PCI cath labs that we have in Sweden, of which there are 31. So we report on national registry, the information in regard to patient characteristics, what we did during the procedures, and then by merging all this information with our death certificate registry and other registries that we have on national level, we can look at the long-term health care outcome in patients that are treated, for example, with PCI or underwent diagnostic procedure of different kinds. That's one of the late-breaking clinical trials that we will present the results on Tuesday, 8:30. So we presented data that are similar but in another patient population. So importance of pre-treatment with P2Y12 receptor inhibitors in patients with STEMI. It was last year. And this year we are addressing the same question: what is the importance of P2Y12 receptor inhibition in patients with non-STEMI? So it has the practical importance of this question, clinically important, is whether or not we should pre-treat this patient prior to intervention in the cath lab, meaning percutaneous coronary intervention. So what we showed last year is that it doesn't seem to be important in terms of long-term outcomes like death or complication rate. But in this year, we are presenting data in patients with unstable angina and non-STEMI based on 65,000 patients who were divided in 60,000 that were pre-treated and 5,000 that were not pre-treated. So what we will report and show is that there is no difference in terms of death at 30 days and 1 year. There was no difference in terms of stent thrombosis at 30 days, but pre-treatment, if started before the cath lab, was associated with a higher rate of complication in terms of bleeding, minor and major bleeding, which is an important real-world evidence that replicates basically the data that has been presented a couple of years ago in a study that's called COAST. We did a prospective evaluation of change in practice. So I come from the southwest part of Sweden, so our county is called Västra Götaland. It has 1.7 million inhabitants. It's approximately 80% of all population. And the data from our region contains 20% of all that is in SCAAR registry. So what we did back in 2016, in the middle of 2016, we decided to stop routine pre-treatment and to evaluate prospectively what does that change in the practice has, how it reflects in patient outcome later on. So that's a part of the finding. So what we saw is the change in practice was associated with less risk, lower risk of bleeding that we have shown that the whole SCAAR population has higher risk if pre-treated. So in one way, we have increased risk in total population in the SCAAR, and in a subgroup, in a sub-study, where we prospectively evaluated the change in practice from routine pre-treatment to no pre-treatment, we ended up in less risk for major and minor bleeding in patients with unstable angina and non-ST elevation myocardial infarction. Those are the major findings. I hope it will have influence on how we treat these patients, because what we don't want to do in healthcare system is to expose our patient to unnecessary risk-taking and unnecessary complications. If we have a treatment strategy that is futile or even is associated with harm, so of course no one will accept any unnecessary complication or harm. So we all agree with that. So our data, based on 65,000 patients, is important in a way that it provides the evidence and confirms what we have seen from randomized clinical trials. And I hope will probably increase the patient safety if we switch the strategy from routine pretreatment to not pretreatment with P2Y12 receptors inhibitors in patients with unstable angina, non-STEMI, and also STEMI that we showed last year at the ESC meeting. So that's the hope that I think. And we provide evidence from the real world, as we call it, when we present data from national registries. We will, of course, continue to evaluate year after year what's happening with these patients. We will have more and more patients that are not pre-treated, so that cohort will increase. So we'll continue to follow up short-term and long-term outcomes in terms of hard endpoints like death, stent thrombosis, myocardial infarction, and complications such as major and minor bleeding and stroke or neurological complications. So those are the clinically most important variables when it comes to the patient safety.